Hello everyone, welcome back. This is Dr Ranjith, your pathology educator at Unacademy. So here we are with one more session of pathology nuggets, detailed case discussion for postgraduates. And as usual, we'll be seeing the same thing. I'll give you a tiny history which might be relevant, which might not be relevant, and a few images following that. I want you to describe the images. I'll give you maybe a pause of few seconds. Just think how you want to describe the images in your head, and I'll describe the images as well myself. Then we'll see how to approach the case and possible IHC if I want, and the differential diagnosis, whatever is required, and all the confounding things for the case, right? So, and we have started a case series lectures for postgraduates, a series of lectures which are the form of special classes which will be available in the Unacademy app, and you can attend whenever you want, wherever you want, and all of them are free of course. So we hope together we can learn more and make the residency as well as your post-residency way of diagnosis and the art of pathology much easier and comfortable. Fine. So if you're ready, we will go to the next pathology nuggets. I think this is pathology nuggets case 13. If you missed any one of them, please go back and see the YouTube channel. You'll have all the pathology nuggets. It might come handy for your exam or your diagnosis in real life. Fine. Okay, let's go ahead. It's a 32-year-old, a lesion in the left foot. See, I'm just going to give you an approach of when I have a history, what all I can think. It's a left foot lesion. So foot lesion, it could be from the skin, any of the skin malignant lesion, epithelial or mesenchymal. It could be benign or malignant as well. So if I go down, skin has your subcutaneous tissue has blood vessels. So it can be hemangiomas, it has fibroblasts, it can be any sarcomas. Definitely have a mesenchymal stem cell, can be any sarcomas. If it is an hematolymphoid malignancy, the shin of tibia and the foot are common sites for your cutaneous DLBCL and anaplastic large cell lymphoma as well, right? So this in a broad perspective. If it's going to be linked with my joint cavity, I could think of an giant cell tumor of the tumor of the bone, or anything related to synovium or the tendon sheath as well. So these are the broad differential diagnosis which comes to my mind when I would think of a left foot. Always have this approach. You think of as what are the possible differential diagnoses. When you imagine like this, most of your answers will fit into it. Which will not fit into it are the rare ones. We'll ignore them for now. Fine. So let's go ahead and see what it is. Okay, the first image. As I said, I'll give you a couple of seconds and for you to look through the image. And now let's see and diagnose what's there in the image. This is a scanner view. What I can see here is skin. My epithelial tissue is there, and there's lots of dermis here. It's a foot lesion, right? So the amount of collagen is expected. And what I see here is I see something here. This is what I presume the lesion is, because this is not looking perfect, right? So I'm having a completely normal epithelium, at least hope so in the image. I'm having a completely kind of defined lesion in the dermis, right? So with this image, I might probably rule out all the epithelial malignancies because the squamous epithelium looks good. So unlikely to be a squamous cell carcinoma or a melanoma of the foot because it's way down, right? And it's way down. So my first possibility here is sarcoma or an hematolymphoid malignancy based on this image, right? It might change when I go to the higher power, right? So on scanner view, this would be my differential diagnosis, right? Let me go to this little bit of more higher power. It's again reiterating the fact whatever you saw. It's kind of a delineated thing, though it's not capsulated. It's definitely a delineated mass. Again, I think these are the muscle fibers in the dermis and the collagen tissue. So I'm having something which is totally in the part of my dermis. So in this image, what I can appreciate is I do have pleomorphism, because even if it's a low power, you can see definitely areas which are dark blue in color. So I hope these are the hypochromatic enlarged pleomorphic nuclei, but still I want a much higher power to say whether it's correct or not. So I do have lots of pleomorphism. So I think of a malignant lesion in the dermis, most likely arising from any of the mesenchymal tissue, most likely a sarcoma. More than a benign tumor, I think of a sarcoma. And the next thing which you can appreciate here clearly is lots of clear areas, right? So when I have clear areas, it could be anything. There's clear cell sarcoma, which comes from the top of my mind. It's a melanoma of soft parts. It could be a melanoma itself. It's the greatest mimicker of everything, right? So I have different possibilities here in this image. Let's go a little bit deeper and let's see what is there. So now this image focuses entirely on the lesion, right? I don't have anything in the normal dermis. What I see is I have lots of fibrous tissue here, which is kind of making the lesion lobulated, right? Kind of a lobulated mass here. And I do have the tumor cells here. Again, this is a low power image. Here also I can appreciate the darkness, the pleomorphism. So it's definitely a high grade lesion. It's definitely not a low grade lesion. You can definitely see the pleomorphic cells here. Though it's a scanner view or maybe it's in 10x, I can still be able to appreciate the pleomorphism here. Fine. Let's go ahead. There are 3 more images. Let's see if anything clue comes to our head. Okay, a little bit of a higher power. Yes, it's definitely the lobulated mass. I can see cells. I am seeing again the clear areas, little bit of eosinophilic cytoplasm plus clear cytoplasms admixed. And maybe is it forming a glandular architecture of anything of that sort? You can see this, right? You can see that it's kind of forming a circle here. Kind of, in some places it's kind of forming a circle. I might not call it glandular, I might call it something. I have something in the mind. Let's see if it is true in the next image. Yeah, it's perfect. See, this is definitely a higher power image. One thing is very, very prominent for me is it is pleomorphic. It is not a benign lesion. Definitely is a pleomorphic cell. It's a sarcoma, most likely. What is more convincing for me here is this. Look at this. You have a perfect, in most of the places, a perfect rounded structure. We call this pattern. Everything is based on pattern in the pathology. So under the microscope for diagnosis of every cancer, it's mostly based on pattern. So this pattern I'm going to call it an alveolar pattern. It's looking tiny like alveoli. It's not a gland. It's not having a lumen. It's not a nest because I'm having only 2 or 3 cells. It's kind of forming an alveolar pattern. So when you say alveolar pattern, I do have few differential diagnoses in my mind. You must have heard about alveolar rhabdomyosarcoma. What might be a bit against for me for my alveolar rhabdomyosarcomas, they are more dense, the cells, and have the pink elongated eosinophilic cytoplasm, the rhabdomyoblast. I'm not seeing them. So second thing which can have the same pattern is granular cell tumor. Granular cell tumor is a benign tumor, so unlikely to have this pleomorphism. The third thing which can have this pattern is alveolar soft part sarcoma. It's alveolar, soft part, soft tissue, sarcoma malignant, right? Let's go ahead. There's one more image and let's see what it could be. It's perfect. I think you will be able to appreciate the alveolar pattern much more. The alveolar pattern, it's not only that, one of the classical finding of this tumor is it looks like the cells are falling into the lumen, right? It's kind of degrading into the lumen. And cytoplasm is also kind of becoming from eosinophilic, becoming a little bit clearer, right? So that's a very, very characteristic finding of this tumor. I have differential diagnosis here. Again, main differential diagnosis will be, as I said, alveolar RMS, my granular cell tumor, or my alveolar soft part sarcoma. Alveolar soft part sarcoma is much more higher about because it's not a granular cell tumor because it's pleomorphic, it's a sarcoma, and I don't see any rhabdomyoblast, no rhabdoid cells per se. They're all polygonal cells with eosinophilic cytoplasm, not a rhabdoid cell. So it's not a rhabdoid cell, I'm going to rule out that as well. So my first preliminary diagnosis here is ASPS. ASPS, though it is rare, it can definitely come in an exam case for you, right? Alveolar soft part sarcoma. I hope you must have seen cases. If you're not seen cases, this could be a case for you to open this spectrum. Because you should not miss it for something. They are malignant. It's not that they are very highly aggressive. They are malignant for sure. I should not mistake it for a granular cell tumor, which is completely benign. So it's common in soft tissue. It's common in the extremities. Granular cell tumor common in the oral cavity. I can have alveolar soft part sarcoma rarely in my oral cavity as well. Fine. So we'll just have a quick description of what the textbook says about alveolar soft part sarcoma. These are the classical description. Hopefully, if the description matches to our microscopy, whatever we saw, our diagnosis is correct. It's characterized by uniform organoid nests of polygonal tumor cells. Perfect. We had alveolar nests. All of the tumor cells were bigger. They were not rhabdoid. That's what I'm saying. They were not spindle shaped. They're not rhabdoid. Right? It was a polygonal cell, separated by fibrovascular septa for sure. Capillary was there. We didn't highlight and see about the capillaries, but definitely they will have dense amount of capillaries. Because all of them are alveoli. When I have multiple alveoli, in the center I'll have definitely capillaries. Right? Within the nest, there are prominent cellular disc cohesion. Right? That's what I meant. The cells appear like they are falling off. They are not cohesive, imparting character to a pseudo-alveolar pattern. It's kind of falling off. It kind of forms like a pseudo-alveolar pattern. Intravascular extension of the tumor is usually present, though we didn't concentrate that in this biopsy. But yeah, it might be present if we search because of malignancy. Every sarcoma will go to the hematogenous route and can definitely spread to the intravascular route. The cell is very, very characteristic. They do have a distinct cell border and abundant eosinophilic to clear. That's what we saw again. The low power, what was striking for me was the clear cytoplasm. When we went to the higher power, we saw the pink cytoplasm coming inside along with the clear cytoplasm. And they did have granular appearance. That's what we said, that it was kind of falling off. It was kind of disintegrating. The disintegrating appearance gives me the granular. So if it's densely eosinophilic, I won't see the clear nature. It's completely clear, I won't see the eosinophilic nature. They are like in between, a clear and a eosinophilic cytoplasm. That's very, very characteristic of an alveolar soft part sarcoma. So it is an IHC based diagnosis, but with a very, very strong clinical suspicion on a microscopic suspicion. You have to suspect this. I cannot diagnose just based on IHC because I cannot apply random markers. So the pattern is important, the cellular discohesion is important, the cytoplasm color is important, and your pleomorphism is important to differentiate from others. So what IHC we can do is, this is taken from the Foundations of Pathology. It's a very, very good textbook. If you want to have a quick review, you can just go to them and see what are positive and what are negative. The environmental in positive has to be, because in mesenchymal lesion, epithelial and melanocytic markers are negative. See, this becomes very important. At least not epithelial. I won't worry much about an epithelial marker because it's not definitely it's not an carcinoma. It is totally unrelated to my epithelium. So if it is going so close to my epithelium, I might have a differential diagnosis of carcinoma also. But melanoma, yes, because clears the sarcoma, the melanoma of soft parts, or even a simple malignant melanoma, which can be a greater mimicker, I need to know them. I have to do an ascendant. If you have a confusion, both your clear cell sarcoma and my melanoma any melanoma will be positive ascendant. That will be negative for ASPS. Desmin will be inhibited. This again, it's very important because my other differential diagnosis alveolar RMS. So alveolar RMS, my desmin, myogenin, myod1 negative nuclear expression will help me. What it is said is, though it is not perfectly correct, alveolar soft part sarcoma might be positive for myogenin and desmin, but in the cytoplasm. That's why it's classically mentioned that the nuclear expression of myod1 and myogenin will be negative. That helps me to differentiate my alveolar rhabdomyosarcomas. The TFE3 is a game changer because this kind of tells me and seals my diagnosis. We did have a case, not only this, other one, it was I think around the knee joint somewhere. I'm not exactly sure about the location. So we had lots of difficulties in diagnosing them, and the final thing which resorted was TFE3 and the cytoplasmic myogenin and myod1, because we researched for them a lot because it was not an easy thing. We didn't have an alveolar pattern, but it was an alveolar soft part sarcoma. We signed out it because of the TFE3 positivity and also the corroborative findings in the histopathology. Fine. So this is about my IHC and my histomorphology, how I can diagnose an alveolar soft part sarcoma. Next thing is the closer DDs. The DDs can be anything. See, if it is in this not connected to the epithelium, I can easily think of a metastasis, right? A mets from a renal, clear cell sarcoma, or adrenal, like it's written, can come. If it's in the foot, I won't have a problem. Let's say somewhere in the upper extremity, close to the like a lymphoid area, close to that. It could be that. I could think of that. On the lower back, I could think of that. Metastatic carcinomas, especially renal, adrenal, hepatocellular, are possibilities. Why these three especially is, again, kidney, hepatocellular, adrenal. All these can have eosinophilic to clear disintegrated cytoplasm. So I can easily mistake them for that, right? Paraganglioma, again, as I said, that if it's in the upper area, the upper extremity is close to the head and neck. It's a very, very close differential diagnosis because the pattern. Paraganglioma also will have the nesting pattern. Right? It will have a classical nesting pattern. As paraganglioma, it's going to be positive for the neuroendocrine markers, and the sustentacular cells will be positive ascendant. Melanoma, especially, is, as of me, my main concern is this person, the granular cell tumor. Other things for sure you'll be able to differentiate. Keep in mind, paraganglioma can be very, very tricky if the ASPS is in the head and neck region. Right? Granular cell tumor, that's what I'm mentioning as GCD. They might express TFE3, so don't go with the TFE3 alone. But the cytological atypia will not be there, and most of them show a very, very strong ascendant positivity. I said the melanocytic marker will be negative in ASPS, so they will not be ascendant positive, right? So these are very, very classical findings seen in your alveolar soft part sarcoma. I don't want you to mistake for granular cell tumor. Granular cell tumor, there is a variant called malignant granular cell tumor, which might become very difficult for me, but they also will be ascendant or SOX positivity will be retained in granular cell tumor. That will not be there in alveolar soft part sarcoma. Fine. Hopefully it was clear. This is a good case of alveolar soft part sarcoma. Hopefully in future, if it comes in exam, great for you. I'm just going to leave the thing with an open-ended statement. There is a normal stain which I can do for alveolar soft part sarcoma. I wanted to comment on that. The granularity can be picked up with a normal stain, not an IHC. Please do comment on that, and let's see more cases in future. And do follow me on the Unacademy app. You will have lots of special classes for postgraduates there. Every postgraduate special class will start with PG, so that you know that it's for postgraduates. We had discussed about endometrium and cervix before, and hopefully when everything settles here, we'll start with your ovary as well. Fine. And you can watch them anytime. You can interact with me. I'll ask questions, because always interaction makes us do more mistakes, at the same time learn more from the mistakes as well, right? So there'll be polls. I will introduce few MCQs for you based on whatever diagnosis we make, which might be helpful for your NEET SS, oncopathology SS, or if you're preparing for your FRC path or FRC MAT, that might help you as well. I'll get questions from the FRC database as well. I'll add it to it, so it will be helpful for us, because in FRC path the main concentration will be on skin and soft tissue, which is a bit rare in our country. So we have to be strong in skin and soft tissue, and we'll read them in the form of intermittent polls. Fine. And you cannot miss a class. You'll have notification once you enroll to it. You can enroll to all these special classes using PathoCups as the code. Fine. And you can download the PDF, which will be available readily for you after the end of the class. Maybe give some time, it will be there, and you can download and use the images for later reference. And you can attend it in your laptop or mobile phone or wherever you want, on your tablet. Fine. There's no restriction for that, and you can attend. Fine. So thank you for your time. See you soon with one more pathology nuggets. Till then, bye bye from Dr. Ranjith. Bye bye.